Welcome to Pour Splash Drip, a retrospective of famous artist Jocelyn Peacock's finest action art pieces. As you'll see, the gallery will soon be filled with some of her most classic works. This is the perfect setting for our sketch on postpartum hemorrhage, especially since all the art has already been delivered. This one's a really important topic because postpartum hemorrhage, abbreviated as PPH, is still the #1 cause of maternal death worldwide. The American College of Obstetricians and Gynecologists defines postpartum hemorrhage as blood loss of 1,000 milliliters or more, or blood loss resulting in signs and symptoms of hypovolemia within 24 hours of delivery. We're going to symbolize postpartum hemorrhage with a can of red paint, or a sculpture of a can of red paint. This can holds 1,000 milliliters to help you remember that that's the cutoff for a hemorrhage. And the sun's there to remind you that most of the time this is bleeding that happens within 24 hours of delivery. More on that in a sec. See? Who said modern art can't be representational? An older definition took into account whether the delivery was vaginal or cesarean, but this is no longer part of the definition of postpartum hemorrhage. Remember how we just said that PPH is defined as bleeding that happens within 24 hours of delivery? Well, this is the case most of the time, but to truly encompass all the bleeding that occurs due to delivery, postpartum hemorrhage is further divided up into primary and secondary postpartum hemorrhage. Primary postpartum hemorrhage occurs within the first 24 hours after delivery, so we've represented it with the sun painting in primary colors. Secondary hemorrhage occurs between 24 hours post-delivery and 12 weeks postpartum. That's approximately 3 months, which is why there are 3 moon paintings over here on the right. These paintings are smaller and secondary to the primary color sun painting. Complications of postpartum hemorrhage are all going to be represented on this art critic known for writing complicated reviews. The complications include hypovolemic shock due to blood loss, DIC, represented by our recurring symbol, DICE, acute kidney injury that can lead to renal failure, represented by this cracked kidney earring, ARDS, represented with our recurring symbol, the shark, this time as very fashion-forward shoes, and finally, Sheehan syndrome. Sheehan syndrome, represented by this art critic, Miss Sheehan, is when lack of blood flow to the pituitary causes pituitary necrosis that can manifest after delivery as inability to lactate and no return of menses. Wow, look at her purse. A pituitary bag covered in skulls. Woman knows how to coordinate. Normally, after the baby is born and the placenta is delivered, the uterus should contract down and tamponade all the large blood vessels that have been feeding the placenta during the pregnancy. If this doesn't occur, it's called uterine atony, or an atonic uterus, which we've represented with this big floppy canvas. Uterine atony is by far the most common cause of postpartum hemorrhage. It can be due to muscle fatigue, as can happen with prolonged labor, or oxytocin receptor saturation, as can happen with prolonged Pitocin use. Apart from these causes, postpartum hemorrhage can also occur due to retained placenta, uterine inversion, or a previously unrecognized placenta accreta. Sometimes, a piece of amniotic membrane or placenta can be left in the uterus after the 3rd stage of labor. This is called a retained placenta, or membrane, and it's represented by this thick blob of paint stuck to this other splatter painting's canvas. Anything that's retained in the uterus can cause uterine atony because it prevents the uterus from contracting down all the way. Now moving over to this side of the gallery. Ugh, how embarrassing. This painting seems to be inverted. Or maybe the late Jocelyn Peacock wanted us to talk about uterine inversion next. Uterine inversion is when the delivery of the placenta or excessive cord traction can pull the uterus inside out. This, as you can imagine, also makes it more difficult for the uterus to contract down. A placenta accreta means that the placenta is morbidly adherent to the myometrium. Just like the spilled plate of food seems to be strangely adherent to this muscle painting. No one said modern art made sense, kids. Anyways, as we covered in our abnormal placentation sketch, placenta accretas are treated with cesarean hysterectomies. They're a big deal. However, if an accreta hasn't been recognized during the prenatal period, when the unsuspecting provider attempts to remove it, it'll either get stuck completely or be torn to shreds. Both of these scenarios can cause massive hemorrhage due to either atony or a disrupted placental site. Let's move on from uterine atony and its myriad causes and focus now on lacerations and maternal coagulopathies, which can also cause postpartum hemorrhage. Lacerations, represented by the big slash in this painting, are due to the traumatic passage of a baby through the birth canal. They can pretty much occur in any area that the baby or a provider touches, such as the periurethral, labial, vaginal, perineal, cervical, and rectal areas. And finally, known and unknown maternal coagulopathies, represented by this red, wet paint that's dripping off of its canvas, can also cause PPH. These coagulopathies are either due to genetic diseases, such as von Willebrand disease or hemophilia, or an acquired syndrome, such as the thrombocytopenia that can be found with preeclampsia with severe features. Now let's move on to our patient presentation. The chief complaint for any patient with postpartum hemorrhage is, well, a lot of bleeding right after delivery or within 12 weeks of delivery. It's going to be pretty obvious what's happening. Your patient just had a baby and she's gushing blood. What you're really going to want to keep an eye out for are all the factors that put her at higher risk for postpartum hemorrhage so that you can anticipate that this may happen and intervene before things get too serious. Let's start off with a typical patient's demographics. Those with a BMI greater than 40 and who are multiparous are at higher risk for uterine atony and therefore postpartum hemorrhage. Anything that causes overdistension of the uterus, such as multifetal gestations, polyhydramnios, or suspected fetal macrosomia, is also a risk factor for postpartum hemorrhage. All of these things are represented in this woman's uterus purse, which is holding multiple buns and is overflowing with water. And hey, one of those buns looks pretty big. Now we'll go over a few things in a patient's past medical history that predispose them to postpartum hemorrhage. After that, we'll cover the things to look out for in the current labor course as well as delivery. A history of postpartum hemorrhage is a risk factor in and of itself for postpartum hemorrhage in the subsequent pregnancy. That's why we've put one of Jocelyn Peacock's famous red splatter paintings on the cover of this exhibition catalog. In terms of past surgical history, prior uterine surgery can cause a scar that the placenta is more adherent to than normal, which makes it a risk factor for retained placental tissue. We've represented this with a palette knife on the cover of this art history book. Keep an eye on the patient's labor course, because there are many things that can occur that also increase the risk for hemorrhage. Prolonged labor and prolonged use of oxytocin, which often go hand in hand, are well-known risk factors for postpartum hemorrhage because basically the uterus is tired by the time the baby is born, so it just can't contract anymore. We'll remind you of prolonged oxytocin administration with the sculpture of an ox with long horns. Chorioamnionitis, an infection of the amniotic membranes, is also a known risk factor. We'll represent the amniotic membranes with these latex balloons that have caught fire from being too close to the gallery lights. Why doesn't everyone look more concerned? Oh, well, maybe it's because the smoke detector abrupted off the wall. Which brings us to another risk factor for PPH, placental abruption. Placental abruption can cause a consumptive coagulopathy that can inhibit mom's ability to maintain hemostasis after delivery. You should suspect placental abruption when a pregnant patient comes in complaining of painful vaginal bleeding. A lot of times you'll deliver the baby pretty soon after recognizing this, so keep an eye out for continued bleeding after the baby is born. Mom could have lost a lot of blood prior, which could set her up for that consumptive coagulopathy we just mentioned. Magnesium sulfate, represented by an art magazine, that's given during labor increases the risk of hemorrhage after delivery. You'll see patients with preeclampsia with severe features given a magnesium sulfate infusion during labor for seizure prophylaxis. General anesthesia, which is done at the time of an emergency C-section, sometimes called a crash or stat C-section, also causes uterine atony. If a patient is on therapeutic anticoagulation, and if they've taken it recently, it could be messing with her ability to clot appropriately. We'll remind you of these blood-thinning medications with this war is hell sign, which should remind you of warfarin. Though, quick side note, don't use warfarin in pregnancy. It crosses the placenta. There are also things that can happen during delivery that increase a patient's risk for PPH. One of these is operative vaginal delivery, either by forceps or vacuum. The reason that this increases the risk of PPH is that it can cause maternal obstetric trauma, such as vaginal lacerations. Macrosomia is also a risk factor for obstetric lacerations, because, well, the bigger the baby. Excessive cord contraction and a short umbilical cord are both risk factors for uterine inversion, which also impedes the uterus's ability to contract down. The inverted painting is hanging from a short, tense cord to remind you of this association. Finally, amniotic fluid embolism is a catastrophic obstetric emergency that can occur anytime during labor and delivery, which causes a massive coagulopathy. This is often fatal and, unfortunately, cannot be predicted. Okay, now moving on to our objective findings. If blood loss is severe, you'll see tachycardia and hypotension, represented by our recurring symbols, the raised heart watch and a fainting person, respectively. However, these vital sign abnormalities usually don't show up until the patient has lost a lot of blood, so don't wait to do something until you see these vitals. If the cause of hemorrhage is atony, you'll feel a boggy uterus on bimanual exam, represented by this kid's hand on the big floppy canvas. Instead of feeling like a firm, muscular ball like it should, the uterus will feel floppy and squishy. If the uterus is firm and there's still continued bleeding, then you need to consider other causes, such as lacerations. Lacerations can usually be seen on a thorough examination of the lower genital tract. When you're doing your exam, move systematically, inspecting the area around the urethra, labia, vagina, perineum, rectum, and cervix. Sometimes you may identify a hematoma, or concealed bleeding. On exam, you'll want to note if the hematoma is expanding, and if it is, how rapidly. If you see a globular mass at the introitus after the placenta has been delivered, make sure you consider uterine inversion, as this could be the uterine fundus delivering through the birth canal. Yikes! This globe lamp next to the inverted painting should help you remember this terrifying finding. There aren't a lot of studies you'll get in the middle of a postpartum hemorrhage, but one that could be helpful is a bedside ultrasound. Ultrasound can help you determine if there's any retained placenta, which, if there is, can show up as a thicker endometrial stripe. Now for our assessment. In terms of what you're going to do as a hemorrhage is happening, you must keep an eye on how much blood is being lost. During a delivery, this should always be an assigned person's job, even prior to a hemorrhage. It becomes even more important to quantify blood loss during an ongoing hemorrhage. This is done differently at each institution, but it's usually a combination of measuring blood volumetrically and weighing soaked sponges and towels. Once you've decided that the patient is in fact having a postpartum hemorrhage, the next step is to figure out the etiology. A way to remember the causes of postpartum hemorrhage are the 4 T's: tone, trauma, tissue, and thrombin. Tone stands for uterine atony, trauma is any type of laceration, tissue refers to retained placental tissue, and thrombin should remind you to consider coagulopathies. Go through the 4 T's in your head each time you encounter a patient with postpartum hemorrhage in order to systematically review every possible cause of bleeding. Another way to divide up your thinking about postpartum hemorrhage is by time course. Primary postpartum hemorrhage is usually caused by uterine atony, lacerations, retained placenta, unrecognized placenta accreta, uterine inversion, or coagulation disorders. Secondary postpartum hemorrhage, or hemorrhage that occurs 24 hours or more after delivery, is usually due to retained placenta, infection of the endometrium, and coagulation disorders. Treatment will depend on the cause, and will all be symbolized around this bar over here. Always think of your ABCs before you start treating the primary cause of bleeding. Once you recognize a hemorrhage, make sure your patient has 2 IVs in place and start volume resuscitating her with IV fluids. Also, have someone call the blood bank so they can start getting blood products ready in case you need to give her a blood transfusion. We'll remind you of this important step with our gallery sponsor, the blood bank. The red wine at this party must be good if they're behind it. Now we're going to go over treatment cause by cause, starting off with the most common, uterine atony. The first intervention for uterine atony is a bimanual massage. What this means practically is that the provider compresses the uterus between his or her hands, with one hand pushing up on the cervix from below and the other hand on mom's belly pushing the fundus down to meet the other hand. This can stimulate the uterus to contract so that it effectively tamponades the vessels that have been bleeding. We're going to remind you of this very important intervention with this bartender doing a new move, massaging a drink. J. Peacock must have liked her drinks massaged, not stirred. If on bimanual exam you feel a boggy uterus, one of the first things you should do is empty the bladder via a Foley catheter. Sometimes a full bladder can get in the uterus's way and impede the uterus from contracting down adequately. If bimanual massage is insufficient, the next intervention is to give uterotonics, symbolized by the sign for gin and tonics. These are medications that encourage uterine involution. There are a few options here, so we'll go over each one as well as their contraindications. The first is a drug that's used during labor to stimulate contractions, Pitocin, the synthetic form of oxytocin. Just like in labor, this drug binds to receptors in the myometrium to cause myocyte contraction. There are no contraindications to this drug. Methylergonavine, symbolized by this morning glory flower, whose trade name is Methergin, is an ergot alkaloid that causes smooth muscle contraction and vasoconstriction. These are great features to have if you're bleeding, but not if you're already hypertensive. So Methergin is contraindicated in those with hypertension. This includes women with preeclampsia. Prostaglandin F2 alpha, also known as Hemabate or Carbaprost, is another uterotonic used for postpartum hemorrhage. It functions by constricting smooth muscle. We're going to represent this one with our recurring symbol for a prostaglandin, the Pro-Slugger bat. It's in a cardboard box to remind you that this one is Carbaprost, and the box is labeled Fake Art to remind you that this one is Prostaglandin F2 alpha. Remember these letters, you'll get tested on them a lot. Because this med can constrict the smooth muscles in the bronchioles, it's contraindicated in those with asthma. Yet another good reason to know your patient's past medical history prior to stepping into the room. Also, a gnarly side effect of this med is profuse and pretty instantaneous diarrhea. So make sure to warn the patient about this when you give Hemabate. Misoprostol, also known as prostaglandin E1, is not FDA approved for postpartum hemorrhage, but is used very often for this cause. The big advantage misoprostol has is that it doesn't require IV access, usually it's given rectally or sublingually, and it has no contraindications, unlike Methergin and Hemabate. So if you need to give your patient something quick or your patient has hypertension and asthma, misoprostol is going to be your go-to. We've represented prostaglandin E1 with this empty E bottle that this guy is trying to throw next to the Pro-Slugger bat. You can remember that this one is misoprostol because he missed his shot. Tranexamic acid, represented by this art Exam, is an antifibrinolytic agent given intravenously. A randomized double-blind trial from 2017 showed that tranexamic acid reduces bleeding in up to 30% of women with no side effects. A Bakri balloon is an intrauterine balloon that is distended with saline that tamponads the uterus from the inside out. This is done if there's continued bleeding despite use of all the uterotonics. We've represented the Bakri balloon with this balloon from a nearby bakery that's compressing the pastries. Good thing the chef isn't here to see this one. If a Bakri balloon doesn't work, you need to do more invasive procedures. A B-Lynch suture requires surgical intervention, unless you're already in the abdomen during a C-section. This intervention entails throwing 2 large sutures over the uterus. They'll look like suspenders. That's why this bartender is wearing suspenders too. These big stitches get cinched down to compress the uterus. This intervention should be tried before something more dramatic, such as a hysterectomy, is performed. Uterine artery embolization is done by interventional radiology, and is when they embolize the uterine arteries with gel foam. This occludes them so that they can no longer feed the uterus, which is atonic and not tamponading itself. We've symbolized this one with a mound of yummy whipped cream foam next to 2 red arteries. The straws. The last resort for a patient who won't stop hemorrhaging due to uterine atony is a hysterectomy, symbolized by this uterus wine glass spilling red wine and being thrown away. Because this precludes any future ability to carry a child, this is a risk you should always counsel your patient on prior to delivery. It's also important to counsel a patient about this possibility because this is a decision that usually has to happen very quickly if she's losing enough blood to warrant the surgery. However, if uterine atony is due to retained placenta, you should try to remove the placenta before all the stuff we just talked about. You can attempt a manual removal at bedside, and if this isn't doable, you can move into the operating room to perform uterine curettage. Okay, that's it for the treatment of atony. Now let's move on to the treatment for lacerations. After you've done a thorough exam of the external and internal genitalia and have identified that the bleeding is coming from a laceration, the treatment for this is to sew the laceration back up. If there's poor visualization or the patient can't tolerate a bedside procedure, then you and your team should move into the operating room to do a thorough repair. If you identify an expanding hematoma, you can try packing the area to apply pressure to the site. Or if the hematoma continues to expand, head to the operating room to surgically control the bleeding or call interventional radiology for embolization. If a coagulation disorder is the cause of the hemorrhage, you should replace the deficient factor. For example, in those with DIC, fibrinogen is usually very low, so for this you'd give cryoprecipitate. For those with hemophilia, you'd give factor 7A. Many providers do what's called active management of the third stage of labor to prevent hemorrhage and a retained placenta. Remember, the third stage of labor spans the time between when the baby is born and when the placenta delivers. Active management is comprised of 3 components. Pitocin administration, either once the anterior shoulder of the baby delivers or right after the placenta delivers, umbilical cord traction until the placenta delivers, and uterine massage. Okay, looks like we've seen the whole show. But since this is a retrospective, let's look back one more time. This sketch was all about postpartum hemorrhage, defined as greater or equal to 1,000 milliliters of blood loss after delivery. Complications of PPH include hypovolemic shock, DIC, kidney injury, ARDS, and Sheehan syndrome. You can remember the causes of postpartum hemorrhage with the 4 T's: tone, tissue, trauma, and thrombin. By far the most common cause of PPH is uterine atony. Some demographics that put a patient at higher risk for atony are a BMI greater than 40 and multiparity. Pregnancies with uterine overdistension, such as those with macrosomic infants, polyhydramnios, or multifetal gestations, also increase the risk. During labor, keep an eye out for prolonged labor, prolonged oxytocin use, chorioamnionitis, and magnesium sulfate administration. And during delivery, using general anesthesia or a uterine inversion can also cause uterine atony. If any placenta is left stuck inside, that'll cause atony too. If this is the cause of bleeding, remove the placenta manually or via dilation and curettage. For these patients, on exam, you'll feel a boggy uterus, and as the first step of treatment, you should do a bimanual massage and empty the bladder. If the uterus is still atonic, give uterotonics or an antifibrinolytic. If medication isn't enough, use a Bakri balloon. If that doesn't cut it, a B-Lynch suture is next, and then uterine artery embolization. The most invasive but definitive treatment for postpartum hemorrhage due to uterine atony is a hysterectomy. Another common cause of postpartum hemorrhage are lacerations, which can occur anywhere along the genital tract. Risk factors for lacerations are big babies and operative vaginal deliveries. These are treated by repairing them, either bedside or in the OR. Finally, coagulopathies make up the final category of causes of PPH. This can be due to an inherited coagulopathy or an acquired one from placental abruption, pharmacologic anticoagulation, or amniotic fluid embolism. For these patients, you should transfuse the deficient factors. In terms of prophylaxis, active management of the third stage of labor to promote uterine contraction and prevent a retained placenta involves giving Pitocin, massaging the uterus, and umbilical cord traction. And that's the whole show. We hope you enjoyed this little jaunt through the gallery and that the critic Miss Sheehan didn't ruin the vibe. Beauty is in the eye of the beholder, right? 'Cause I don't know if I get these Jocelyn Peacock paintings. Catch you at the next show. Sketch.